For me, contraception I think is very, very important because half of all pregnancies in the United States are unintended. Of those 3 million unintended pregnancies, about 40% are abortions, 40% are live births, and the rest are miscarriages. So for me, without getting into politics, the best way for me to reduce the abortion rate in this country is to promote effective contraception, and that's what I've done in my various affiliations over the year. The rates are highest among 15 to 24-year-olds, unintended, unmarried women, poverty in Black and Hispanic women. And the current state in the United States is that sterilization is the most popular, 23%, combination pills are 19%, condoms are 11%, depot withdrawal. IUDs are now, as of 3 years ago, become a lot more popular, and they're up around 5%, so they've surpassed the depot and then other methods in this, and the new data hasn't come in with the Implanon yet, but that should be this year. Because of a conference, my disclosures are that I've done research with almost every form of birth control out there. I'm on the OBGYN Devices Committee for the FDA, so I see all these devices, and there's a big disconnect between what people use and what people are satisfied, and also what doctors think and nurses think that their patients like the best. So in a large study looking at the greatest patient satisfaction, what's your greatest satisfaction? And not what's used the most, but what are patients satisfied with? Vaginal ring, B patch, one combined, and the answer C is correct. So again, it's a pretty close tie between vaginal rings and the IUDs. In fact, there's a study that just came out in the past year saying if you didn't have to worry about money and co-pays and everything else, what would you use? And the IUD and the Implanon injection came out 67% would prefer a long-acting method. This month in the Green Journal is ACOG's new technical bulletin or practice bulletin with the official policies on long-acting contraception, the IUDs, and the Implanon. And we'll go through those at the end. They just came out not even a week ago, and I included it at the end. It's not in your handout. Okay, typical contraindications, again, as part of the FDA. They really care about safety. You know the safety. I listed them in there. They're in your handouts. Hypertension, diabetes, migraines, vascular disease, personal history of breast cancer, what we just talked about, coronary artery disease, liver disease, and jaundice. Now, for about 15 years, there wasn't a lot going on with birth control. There were a few things that came out. So for the 15 years between 1995 and 2010, you had some emerging contraception, the ring, the patch, different forms of birth control regimens. We had a long talk with Dr. Zulak last year about extended regimens. I think they're here. I think they're here to stay. Even though the drugs came out 5 or 10 years ago, studies just in the past year have come out to show that extended regimens, 24 days versus 21 days, when they did nice, non-biased, non-commercial studies, when they took 24 days of the same hormone and 21 days, 21/7 in the same hormones, your decrease in bleeding is about 60 to 70% less intramenstrual spotting, and your decrease in your menstrual period is about 1 day less. So they really are effective. They really do a good job. And I think extended regimens are way, but they're still, if you take a 21/7 and your patient's on it, it's not bad. They're spotting. They're going to spot 1.6 days a month instead of 0.9. And they're going to bleed 4+ days versus 3+ days. So it's not clinically crucial, but if you're going to take 100 or 200 patients in your practice, like in my practice, and put them on birth control, that's 200 calls less if they're going to call you when they spot. And you don't get, the nurses get them. The vaginal ring patch, the new data's come out with the patch. We'll talk about some of that. But basically, just in the past year, since last year's conference, and I went over a little bit for a couple of months for the different quadriphasic pills, and instead of saying all the different names, you know what they are, and we'll go through them individually. But since then, 5 new methods of birth control have been approved, and some major changes in the government's recommendations about them. Well, estradiol, Denogest, and Natasia, I don't think we had a chance to talk about it last year because it was just out after we got the slides presented. And basically, it's a pill that contains estradiol valerate, which in the body is transformed to the natural form of estrogen. So because of it, the body doesn't react, and you have less liver enzyme activity. So that's one thing. They tried promoting it as a natural hormone and bioidentical, and the FDA shot them down, so that slowed things down. Denogest is a nice progesterone that in Europe is approved for decrease in menstrual bleeding, a decrease in bleeding. They tried the indication in the United States, even though the studies have shown that you do have statistically less bleeding with this hormone combination. The FDA didn't give them the approval, which they suggested. So even though last year over the winter you probably had your salespeople come to your offices and drop off a bunch of these pills, your salespeople aren't going to talk to you about it anymore. And it's not because there's anything wrong with these pills. It's because they didn't get the indication to call themselves bioidentical, and they didn't get the indication to claim that they statistically significantly reduce menstrual bleeding. It was at the same rate as the Lysteta, the methylmanic acid that's out there, and they thought they would get the approval. They didn't. It's a 4-phasic regimen. A lot of people make fun about that. It's 4 different doses. The science has worked out pretty good. So, and again, it's been used in Europe for years. The interesting thing is that, and initially my office said, a patient called back and said, I missed the pill. Well, which pill? And what do you do if it's the pink pill versus the yellow pill versus the white pill? And what makes it easy now is that they have a website, and it's even have an app, and you tell your patients that if they're using this pill, to just go to this app, and they put it on their phone, and they just look at it, and it says, and it's the website, and it's something funny like, oh my God, I missed a pill.com, so, something like that. And I always joke it when I'm at the FDA, OMG, I missed a pill, and it just tells you missed this one, you missed the yellow one, you take 2 of these, you missed this one, take 2 of those, and you don't even ask them, just say, go to that website or download the app, and the women that we're dealing with now know that. Again, it's 2 days of 3 milligrams estradiol, 5 days, 17 days, 2 days, and 2 days. There's 2 days where there's no hormone. There's a step down, so you have a little hormone. Again, it helps with intramenstrual bleeding and spotting. And again, statistically, in the studies, the compared placebo-controlled trials, it did help. Just doesn't have approval, so we won't go any further than that. Pearl indexes get confusing. Basically, it's for 100 years. If 100 different women are on a pill, so it's per 100 years. So it works out to a percentage in the long run. For the estradiol valerate, it's 1.64. Again, in January this year, all these pills were approved for birth control. Now we go back, and the FDA, we ask each company to say you have to do a phase 4 trial, and not a phase 4 trial to see, if you have this minor bleeding or that minor bleeding. It has to be 50,000 patients. So every time a new birth control pill is out, they start a trial for 50,000 patients for 3 years. So they have some studies have up to 150,000 women years in these studies, and they're now finding subtle differences. The first one they found subtle differences was the 24 versus 21, which is fine. The second one that was published in the Green Journal, I think it's January, I don't know if it was December and January, it came out and said there is a difference between the birth control pills with pregnancy rates. If you get a pregnancy rate of 1.1 or 1.2 or 1.4 and a pregnancy rate of 2.6, 2.7, 2.9, okay, it's almost double. So again, for my practice of 200 women, that's an additional 2 pregnancies a year. Well, they didn't want to if we're on the pill. Now, it's all due to compliance. That's use on a study. When we do a study, we give them pills, we give them money. They come back next month and fill out their diary. We give them $75, so they're motivated to come back and take their pills, because if they miss a couple of pills and they're pregnant, they get off the pill. We don't continue them on them. Or if they miss a lot in their diary, you all know they don't miss a lot in their diary. They write in their diary, I took it every single day. That's why last year we talked about that nice study that others and we did, where we put the computer chip in the cap of the bottle. When they came back, all their things that they took them 8 o'clock, 9 o'clock, 7 o'clock, 8 o'clock every morning. And then when we looked at the computer chip, the average 3 days a month they didn't open the thing, and 40% of them 2 days in a row they didn't take pills. With the mini pills, if you look at, again, you don't look at your package insert, so that's why I'm going to tell you. If you're in the mini pill, progesterone-only pill, and you miss it for 3 hours, you're supposed to use another form of contraception. Okay? For most birth control pills, it's 12 hours, some it's 24 hours. But there's certain hormones, certain progesterone, that have a half-life of about 36 hours. Drospirenone is one of them. So basically, you may not have the effect of a low dose. You worry about the estrogen. Low dose of estrogen may not help you as much, but you're still getting the effect of a mini pill for 36 hours, and you don't have to worry about taking the timing of the pill. But the main thing is there is a difference in the pregnancy rates. Again, it's subtle. Does one make a difference? I mean, if you have a better compliant population, a difference of 1 in your Pearl Index is going to make a difference. When you take patients that aren't motivated, aren't given the money to be on pills, the average patient will have 9 out of 100, so almost 10% of women on the birth control pill will get pregnant in a year because most of them aren't taking it effectively. Okay, the patch, and you'll again, progesterone-only pills. I put the range that's in the FDA list, because if you make the patients take it every day, or you watch them take it every day, you tell them to take it every day, it works a lot better. If they don't, and they miss, the 3, 4 hours, 12 hours, take it one evening instead of one morning, your pregnancy rate's going to be 3%. Okay, again, leading cost of society for gynecologic is menstrual disorders, and it's about 8% of total wages. I remember when I was at University of Minnesota, it was 3M was a big company in town, and they would come to us and say, we want to deal with our bleeding disorders, not so much disorders, our bleeding, our productivity. We figure we can increase the productivity of our workforce by helping the patients get better control of their problems. Because a lot of women have menorrhagia, and they don't complain about it. That's why we have so much anemia. So heavy menstrual flow costs the employers a lot. It also affects women's lives a lot. And again, that's why you're seeing more and more effort and more research being done on menstrual disorders and menstrual flow. Ulipristal, acetate, FDA approved new birth control early in the year, late last year, called Ella. It's a prescription-only product, prevents pregnancy when taken within 120 hours, 5 days after contraceptive failure intercourse. You get the extra 2 days because if you were going to ovulate 1 or 2 days from now, it prevents that ovulation, adds the 3 days that you would have gotten if you were on levomefolate, preventing ovulation, delaying ovulation. You shouldn't use it as a birth control. Again, this is all straight out of the FDA. Chemically, it's a progesterone agonist-antagonist, and again, it probably inhibits or delays ovulation. It's been available in Europe for a while. It's a 1 30-milligram tablet. Okay, can be used up to 5 days afterwards. Okay, the other form of birth control that you can use up to 5 days afterwards is the copper 7 IUD. The clinical trial results, basically, when you looked at patients up to 5 days, the pregnancy rate was reduced around 68%. When they did a comparative study against levomefolate, it reduced it at 57% or to 68%. It also statistically was better than levomefolate. Okay, 68% or 65%, 67% better in the first 24 hours than levomefolate, and 55 to 60% better after 3 days. So it's a much better efficacy rate. And it's called Ulipristal or Ella. But what the organization has me do is I'm in charge of 5 hospitals now, 180 OBGYNs, and we're trying to coordinate them with the training of the residents and the fellows, is that I'm in charge of accountable care. And accountable care, we'll talk about it next year, because right now it's a little premature, but most big organizations are looking into it, and most small organizations are going to have to merge or become a part of large organizations. And if it's going to occur, and I thought it was definitely going to occur, but a lot of our vice presidents of finance thinks it may get repealed. But if it moves forward, I will predict, and I will tell you now, 50% of whatever organizations that you're in or around you, 50% will change. You can't survive unless you're a $4 billion operation in this environment, and it's going to be harder and harder. Basically the Accountable Care Act takes 25% of the money out of the system. That's where they get their $1 trillion in savings. It's not encouraging you or incentivizing you to become better doctors so that the system saves money. It hopefully will do that too. It takes 25% out of the system, and if you don't want to lose 25% and you want to be the groups that maintain parity, then you've got to be a better group according to accountable care. And it affects contraception in a strange, surprising way. So basically, and they do this through the U.S. Preventive Services Task Force. They come out with recommendations, and those recommendations are important. They're based on, loosely, the fact that the government's decided that $30,000 to $50,000 per year for life is the value of life, $30,000 to $50,000 per year. So when they look at these things, that's why in the news of the past 2 weeks you've heard all the new cancer drugs, or the old cancer drugs, that they're re-looking at and not giving indications to, or they're taking the indications away and everybody's complaining, is because it doesn't fit in that formula. And OBGYN fits in that formula in several ways. But basically, the task force in the past 2 years has made guidelines that affect us. And breast cancer screening, as you heard, went from 50 to 40, lots of controversy about it, but that's what the government says, because even though we know a lot of women have breast cancer detected in their 40s, the number of women who get screened and the number of people who have procedures done surpasses that $30,000 per year. When you look at all the number of breast cancer, but you're still going to pick up breast cancer. So for the American Cancer Society and for OBGYNs, we want to make sure we pick up most cancers. For the government, looking at accountable care, it's not cost effective. So we'll deal with that over the next couple of years. Let's go to the bottom. No routine pap collections, women over 65, same thing. The number of women that can acquire HPV that get cervical cancer is low. It still happens. It's still there. I have 3 patients, but I'm a referral center. 3 patients in my practice who are over 65. Again, we're doing I'm still in the 5th year of these large HPV vaccine trials. We're about to start an HPV vaccine treatment trial. And it's great. The last trial we looked at, the original trials were for women from 15 to 26. The new trials are up to age 99. The only reason we stopped at 99 because the FDA only gave us 2 boxes. Otherwise, there were women that were having sex, that in 90s and 100s that wanted to be part of this trial. And when we looked at numbers, everybody's getting HPV in their 20s and 30s and 40s. There's still a 4 to 5% rate of acquisition of HPV, new HPV, in women in their 60s and 70s. So what happens with this new HPV? You don't screen anymore, don't do pap smears anymore at 65. They wind up getting cervical cancer. Our 3 patients, 2 of them with cervical cancer, we finally went back. Their husbands, nice enough to tell us the truth. Their wives stopped their hormones because of the breast stuff. They became atrophic. They went out and got a girlfriend. And 2 of them said they had girlfriends on the side of which they got HPV, and that's how they gave it to their wife. And they basically essentially said they'd kill their wives. Which the third guy says, I don't know what you're talking about. I didn't do anything. So I don't believe in those recommendations, but the government makes those recommendations. The same thing, we're looking at the recommendations that you can't do pap smears in women under 21. You know what? There's a big difference. I have 2 patients in our resident practice that are 12 years old and are pregnant. They'll deliver when they're 13. But there's a big difference between somebody who gets HPV when she's 13, and goes 21, and who gets it when she's 20 and 21. There's 7-8 years there that I don't like them unscreened. So we're looking at those numbers now. The thing that was important that the government, I don't know if you know, but last year the government told you that you have to tell your women to take folate. If you have a reproductive age woman, a woman who can get pregnant, she has a hysterectomy, she's 35, it doesn't make a difference. But if she can get pregnant, you need to tell her to take 400 micrograms of folate in addition to her diet. You can't say, well, what kind of food to eat? Maybe you eat enough in your diet. You have to tell her. If you don't do it, then you will get in trouble. The risk of spinal tube defects about 1 in 1,000. I mean, you don't want Sure, it may take 5 years if you deliver 1,000 patients, but you don't want neural tube defects in your practice. If you do that and you don't have in your chart that I offered folate, to offer folate supplementation or told her about it, you're going to be in trouble. And my chart, the day this came out last year, I changed it for my checkbox. Do you talk to her about colon screening? Do you talk to her about breast mammograms? Do you talk to her about STDs? Do you talk to her about birth control? I then added a point to talk about folate. Now, why did this come out, and why do I have it under preventative task force? Preventative task force, Medicare and Medicaid, that's all they care about. Medicare and Medicaid, when you're disabled, you get Medicare, no matter what age you are. When you have a spinal tube defect or a neural tube defect, you don't die, you're paralyzed, you're in a wheelchair, and you get Medicare when you're younger. So right now, there's almost 200,000 women, 200,000 persons who have spinal tube defects who are on Medicare, and that's costing them a fortune. So when you look at what the cost is, it's the number 4 highest cost for Medicare for women's care, because you had all these women that are living or men, all these children that are living for 50, 60, 70 years that are on Medicare. It's become a big expense. So they addressed it, and they know you can reduce it by giving folate. So they now, there's a CDC came out and approved it. The ACOG is really good. ACOG, we try not to force things down to you because you'll get in trouble if nothing happens. But ACOG had to follow up with a recommendation saying they encourage you to speak with your patients who are of reproductive age about supplementing their diet with 400 micrograms of folate. It's all official now. This is what you need to be doing. And that's, again, for a contraceptive talk, that's probably one of the most important changes that's in your practice. You have to talk to them. You have a spinal tube defect. This is not in your chart. You're going to be in trouble. Okay? Basically, Drospirenone, basically Beyaz, they added folate to it. And again, when this first came out, I said, I first heard about it at the FDA. I said, what a gimmick, how stupid. Why not add calcium? Why didn't I add vitamin D? Do something. Why add folate? And of course, 3 months later, the government comes out with their opinion. And I said, now I know why. Because, folate's now important. Then I say, why a birth control pill? You get birth control pills and they're not going to get pregnant. And then it turns out that 50% of the women who get pregnant unintentionally are pregnant because they're technically on birth control pills, but they forget it, they stop. 60%, 40 to 60% stop within the first year. Patients don't come to my office with the annual exam, and I see them and I do their gonorrhea, chlamydia, and everything, and then I give them I say, okay, you want me to refill your birth control pill? And they go, oh no, I stopped that 6 months ago. They don't call me the day they stop. They wait till their next appointment and say, yeah, I stopped it 6 months ago. Well, in that time, 20% get pregnant within the first month of stopping the pill. 50% get pregnant within 3 months of stopping the pill. And again, I don't, on average, see them for 6 months. It's 12 months a year. I see half the patients during that time. So combining with a pill seems important. Again, the pill itself, basically, it went out and took the trouble to get the four indications. And one is prevention of pregnancy, PMDD, acne in women over 14 who want to be on the pill, and again, to raise folate levels. And it does it fine, and we won't go through all the statistics. Pregnancy rate per index about 1.4. Again, these are just numbers. You look at them and say, who cares? But again, in a practice where I have 200 women on the pill, which is going to be less, I'll talk more about accountable care. What happens is that you have a pregnancy rate of 2.8. Per index 2.8. You're going to get 1 extra woman pregnant, so I get 2 extra pregnancies a year just because of the pills I pick. Okay, the Safrole is just Yasmin with folate in it. It's a 21/7 pill. I keep thinking, why bother with a 21/7 pill? 10% of use in this country are 21/7 pills now because people like it, they're on it. And again, the difference is an extra day of bleeding, an extra day of spotting. So clinically, it's more important that you take their pill every day. So if they're on it, they like it, that's fine. Okay, in May 2011, 2 studies came out. I don't know if you've heard about it. 2 new studies. There were 4 studies out previously. The FDA wanted to, but it really was forced to address them. Last November, they looked at them. They put them in the package insert. They put them in the PDR. The original 4 studies, 2 said there was an increase, but they found flaws in the study and said they're not reliable. 2 studies were prospective randomized trial with 150,000 women. So there was no difference with levomefolate pills, and that's why they left the pill on the market. 2 new studies came out, again, retrospective epidemiologic studies. We can talk more about them later. The government says, we've seen them, we hear your concerns, we're going to go ahead and look at them and address them. Again, there were retrospective trials. In my early evaluation, I think they're going to give the strength to the prospective trials. Even the authors, people at the same institution said that some flaws with the trials, but we'll get, you'll hear that. It'll probably come out early fall. The government will make their official determination if they need to change the black box, if they need to take the pills off the market, or they'll continue. If you have to have, just as a guess, and this is a guess, it'll continue the same. We have the same problem, an absolute positive, everybody's sure documented increase of VTEs with the patch. Okay, the company does, for years ago, doesn't sell the patch to you anymore, but there's still patients out there. There's still patients that use the patch. They like the patch, even though we know that it doubles your risk for VTE. Why does the government let that? Because the risk of VTE with the patch is 1/10 of what the risk of VTE with a pregnancy. So they'd rather you be on birth control, even if it increases your risk, a little, 1 in 1,000, than to have 100 women get pregnant. Now, another pill, it's just new. Again, we're just talking about new things. We'll talk about anything when we're ready for our break. Low estrogen, low, and that's next year. It'll be low. There is a low formulation. We did research studies on like 10, 15 years ago, but the FDA is not going to let us go there. But there is a low. FDA approved just for pregnancy. Again, Pearl Index 2.92. Pearl Index, if you're around 3, you're okay, because that's what the mini pills are. So if you don't have to be the best, but you see there's a difference. So again, if you're using pills with a 1.2 or 1.4 versus pill 2.9, you're doubling your pregnancy rate if they're using it the same. Again, you won. Margaret Hansen, who was a very nice woman I worked with in Minnesota. It didn't make a difference. She used the cheapest pill possible. She knew the difference. She was smart. She wrote some of the papers. But what she did is she gave $15 to her teenagers if they continued to use their pill every day correctly, and she just would go out of her way to do that. So compliance is more important, but we don't have to do that. So in July, just recently, last couple of weeks, what's happened is this is the last. It's brand new stuff that you should know about. Again, because the government says it. When the government says it, ACOG will follow soon. But again, they looked at restrictions on the use of pills, combined hormonal pills, in the postpartum period for women who are not breastfeeding. We'll talk about breastfeeding, but women who are not breastfeeding. Okay, in 2010, they changed it. So they've changed their mind twice already. Okay, but in 2010, women shouldn't be using combined hormone pills again if they're not breastfeeding for 3 weeks after delivery. Okay, and the reason for that wasn't estrogen effects on breast milk, wasn't pills or not effective, wasn't poor. I think postpartum women should be focusing on their baby. Come on, it's increased risk of VTE. Again, the VTE thing is a big deal for the FDA. And again, their official wording is the restrictions put in place because the birth control pills carry a slightly elevated risk of VTE, and women who are just recently pregnant and haven't undone their physiologic changes are at even a higher risk. So for 3 weeks, you can't do it. That was 2010. Now, they looked at the data, and again, just July 8th, they increased that date from 3 weeks to 42 days to 6 weeks. Okay, so you cannot start somebody who's not breastfeeding on birth control pills within 6 weeks. And they looked at when they looked at with risk factors. Now everybody has risk factors because you're 35, you're immobile, you had a C-section, you smoke, preeclampsia, postpartum hemorrhage, obesity. You add all those together. If you have to make sure every person on that list doesn't have one of those things, then you can go ahead and give a pill to 3 weeks. Okay, so basically, 6 weeks you don't give a pill. Okay, don't decide if she's 165 pounds versus 125 pounds, as that's obesity, because you'll get into BMI. And I'm not telling you how to practice, but I'm saying the government says 42 days if you have risk factors, and there are a lot of risk factors. Okay, they looked at 13 studies, and they found that basically the changes didn't get back to normal until after 42 days. And it wasn't a mild increase in risk. It was a 22 to 84-fold risk factor. You can't defend that. Okay, you can't say, well, I thought the risk was small. You're going to say risk of smoking with breast cancer is 7 or 17. No, smoking and lung cancer is 7 or 17, something like that. You know, you can't say, well, it's an 84 risk factor. It wasn't important. So watch it with your birth control pills and non-breastfeeding women. Okay. Again, they only are breastfeeding. No, the ones who are breastfeeding are unchanged except for these additions. So with breastfeeding, you can't use any hormone. It's category 3 if you're breastfeeding for the first month. Okay, so after the first, because it's category 3, don't use. Okay, after the first month, it's category 2. It means there are risks, there are benefits, you know, and probably the benefits outweigh the risk, but it's still a category 2. Okay, now all this is superseded by the 42 days. Remember, you're now talking about a month if they're breastfeeding. If they're obese, had a C-section, anything like that, you can't give them anything for 6 weeks. Just put in your back of your mind, there's 2 things I want you to realize, you know, from this talk. One is talk to your patients about folate, document it on your chart. You know, the risk of neural tube defects, it's, you know, it's there, 1 in 1,000 deliveries. It's going to happen. You know, it doesn't always affect. You can't always stop it with folate. In fact, in October, I present data from some research we've done. There are 10% of patients have this genetic defect that they don't metabolize folate properly at low doses. So you have to go, instead of 400 micrograms, you have to go to 2 milligrams. Okay, and that's a test that's going to come out that's going to tell you that. And it's going to be recommended for all women of reproductive age so we can know which women need the extra folate so we can prevent neural tube defects. I argue with the company that's making it to just price it $20, $30. Because if you get all the women in the country that want to get pregnant, you're going to make a million. But they looked at the $30,000 per year formula, and they think they can charge $300 for it. So we'll see what happens in October. I think they're being greedy, but there'll be a test out there telling you whether you need folate. So folate's one thing. The second thing is don't give people birth control pills, you know, unless you really look at these risk factors before 6 weeks after delivery. Okay, and a diaphragm, you can the same thing in cap for 6 weeks. Okay, so as of this month also, the ACOG has come out with recommendations on long-acting contraception. Why long-acting contraception? You know, it's one of these crazy TV movies where you think everything's going along nicely, but there's really some big conspiracy going on. It's all really one big conspiracy. The government wants you to be accountable for your care. Unfortunately, they're causing the problem. I mean, on all these 2,000 pages of accountable care, nothing addressed medical liability. So they want us to reduce the C-section rate, you know, but, you know, I'm not going to be able to reduce the C-section rate unless you fix the liability problem. The birth control issue that the government's up to is they think it's bad medicine for a woman to come in and to be seen for osteoporosis or for asthma or for menorrhagia, for something, and then at the end of the talk, or at the end of the talk, she says, oh, by the way, I need a refill on my birth control pills, or I need some birth control. Well, at that point in time, since I have longer time because I'm the chair, but you know, you have your 15 minutes, you have your appointments, you're all busy. You can't even bill for a second or third code. So you say, fine, here's a sample of birth control pills, start them this month, and then let me know how you're doing next month, and I'll refill them, or we'll talk about them, or we'll set up a new appointment. But you don't sit there and talk about the benefits of the IUD, the Implanon, you know, all these other ring and the patch. You don't have the time. So it's government's forced us into this rush with their patients. But now they say, oh, it's not good medicine for you just to give people birth control pills and not discuss all the methods of birth control. Well, reimburse us and let us talk to these patients, you know, properly. So it looks like when accountable care comes along, you're going to be graded on how good you are. We'll be okay. 3 months ago, I thought we were in trouble. Two months ago, the government came out and said they're not going to hold OBGYNs to these standards for at least the first year, which will mean 2 years or 3 years for the government. But what their thinking was, what they made their announcement over the past year, is that they want 25% of your patients in your practice to be on non-birth control pill forms of contraception, long-acting contraception. So of course, 3 months later, you know, or a year later, the ACOG comes out with their guidelines for long-acting birth control. So We'll go through them quickly. They're in your green journal, but the last slide is what I want to show you. And that's, so basically, you don't need prophylaxis with IUD. The copper 7's worth up to five days after birth control. You can put them in women with a history of ectopic pregnancy. You can put them anytime after non-breastfeeding women after childbirth, 10 minutes later if you want. Implants, wait for 4 weeks. Again, right after abortion and miscarriage is fine. Wait till 10 minutes after placental separation. We're going to start to do that now. Just we got to figure out, do we bill it as a hospital? Does the hospital buy it and bill it, or we just do it as a pharmacy benefit? The U.S. medical eligibility criteria for contraceptive use, again, less than 4 weeks is category 2. Again, you can read all these things. We'll go through. They have few contraindications. Almost all women, here's the last thing, long-acting methods have few contraindications, and almost all women are eligible for implants and IUDs, okay? Insertion can occur at any time. For women with STDs, you can screen them for STDs, even if they have a high risk. Before, you couldn't put them in with women at high risk unless you screened them first. Now you can put them in women with high risk, screen them, and if it comes back positive, treat them later. You can do biopsies, colposcopies, ablations, excisions, all that stuff with it. The last thing, if you look at your practice bulletins, only twice in the past year have they put the last thing, proposed performance measure, and the other one was maybe something with thrombophilias, I think. But and what they do is they're going to say, we are going to have a performance measure to say there has to be a percentage of your women that are on contraception that are receiving LARC. And again, I saw that this month, and I said, it's just what the government said a year ago when they had us do these demonstration projects. So over the next couple of years, it'll take 1 to 3 years for us. You will be graded on the number of women who are not on your birth control pills or on long-acting methods. So that's why I think it's just important for you to look at all this. I think just very quickly, there are a smaller IUD for teenagers and nulliparous women. There's a subdermal implant. There's new formulations that have come out. There's a new patch that just finished enrolling patients September. The study's going to be closed. We'll be reviewing the data, and then new formulations of the